If your work is to matter to make sure health systems are a force for change, it means being networked. It means being connected to those who are affecting change.
Welcome to the Alliance Lift, the podcast that brings you closer to the people driving change in health policy and systems research around the globe. I'm your host today, Idil Shekh Mohamed. In each episode, we explore the experiences of Alliance alumni making 3 stops along the way, learning from the past, living in the present, and leveling up for the future.
The commitment to gender equality goes much beyond putting certain checklists in grant applications.
Whether they're advancing research on health systems, shaping policies that promote equity or justice, or as in today's episode, strengthening the social, gender, and human dimensions of health systems, our alumni are asking critical questions, challenging the norm, and expanding the frontiers of health policy and systems research. Today, I'm delighted to welcome someone whose work has shaped the field in profound ways, Professor Asha George. Asha has spent her career examining the interface between communities, health workers, and health systems through a governance, gender, and human rights lens. She holds the South African Research Chair in Health Systems, Complexity, and Social Change at the University of Western Cape. She's a globally recognized qualitative researcher who centers on analyzing governance, gender, power, and human rights, and how these play out in the everyday relationships between communities, health workers, managers, and policymakers. Asha has served in multiple global leadership roles, such as the chair of Health Systems Global. She's also the 2025 Thinker in Residence at the Alliance, helping us think through gender equality in HPSR. Good morning, Asha, and welcome to the Alliance Lift. It's a pleasure to have you with us today.
Thank you, Idil. I'm excited to have this conversation with you and to talk further with the Alliance. Thank you.
Fantastic. So this is learning from the past. You began your career working in Mexico with government ministries and UN partners to advance the agendas that emerged from the Fourth World Conference on Women and the International Conference on Population and Development, 2 frameworks that really shape how we think about women's rights and health in the world. What did you take from being part of that movement, and how did it influence the lens you would later bring to health systems and your work today?
So the Cairo Agenda was one of those international conferences on family planning, and it really looked at women's empowerment and gender equality as being key to family planning and contraception. The paradigm shifted, and women's experiences, women's voices, gender equality was put as a fundamental foundation for talking about sexual and reproductive health. There were sections also addressing the role of men as well in advancing gender equality. I think it was a very unique time in which there was so much mobilization by civil society. And there was an opening, a demand that government opened itself up. There were both government negotiations, but also civil society platforms. And it was incredible to hear directly from the women's movement what were the issues that were concerning them and how do we get it onto government agendas. But also understanding how do we broker a more inclusive way of shaping policy. And I think that's critical today as well, as inequality is so much more than it was even then. So it was a striking time, and it was also an agenda that personally resonated with me. I remember reading the Cairo Agenda and thinking, yes, these are all things that I stand for and that I believe and I want to affirm in my work. So it was very exciting to have that personal resonance also in these global agreements, but also be inspired by so many leaders as they forged this new way of thinking. It was fundamentally a paradigm shift driven by activism.
You returned to India to do your PhD, where you worked across community, district, state, national health systems on maternal health from a gender equality and rights perspective. Could you explain a little bit of what drew you back to India in that point of your career? What were you hoping to sort of understand or contribute to in that context that you feel you couldn't have explored elsewhere?
I'm an Indian citizen that grew up in Mexico. And I felt if I was going to work in public health, I felt very strongly I had to work in my own health system. I've never been someone who's learned from books alone. It couldn't be theoretical. I had to be based in my own health system. And that's why I went back. I chose a program that would allow me to work with key mentors. They were researchers, but activists also. They did research because they were concerned about changing health systems to make them more just. They are the ones who taught me public health. And that privilege to be able to work with them across many different initiatives, many of which were not funded. We collaborated because it was the right thing to do. And funding came as we worked on these issues. But it's when you are passionate about certain topics, you connect with people and you create an agenda for change together. And really, those 10 years have created a foundation I always go back to. And I have a huge debt to all those people who marked my time in India.
Before we go into the next segment, I wanted to discuss a little bit about your relationship with the Alliance, which goes a few years back now. But one notable thing was your role as the editor of the 2017 Health Policy and Systems Research reader on human resources for health. When you think back to that reader, what would you say was most significant about it?
We really push the boundaries in terms of looking at health workers as human beings themselves and not just as robots or inputs into a bigger log frame that leads to better health outcomes. They are critical actors in a social system. They're social beings themselves. The reader helped to sort of reframe how we look at human resources for health. Even the term human resources for health is very instrumentalist. So it was a wonderful opportunity to reframe how we look at health workers, their role in health systems, but also an incredible opportunity to develop the reader in a very consultative way. We shaped the outline of the reader consultatively, and we had various webinars where we invited input. We invited people to send their favorite articles. It was a process of public engagement itself. And that's what made the work that the Alliance made possible so exciting around the reader. In the end, it's not just the reader. It's the process of engagement as well in bringing so many people together to input in developing a knowledge output like that.
I also wanted to discuss a little bit about your latest and newest chapter with the Alliance. You're the 2025 Thinker in Residence with us, and you've spent a week here with the Secretariat in Geneva exploring how the Alliance can be more intentional and strengthening their work on gender within HPSR in terms of what evidence the field still needs, what assumptions needs challenging, and how to support researchers who work pushes these boundaries. What motivated you to take on this residency?
It's a wonderful opportunity for me to pause and reflect on my own trajectory. So right from my doctoral degree, the Alliance has always been a friend. And as chair of HSG, the Alliance also was a key knowledge broker. And I think that's what's critical moving forward. Yes, the Alliance has these calls for proposals, and therefore that opens opportunities. But those opportunities are about also creating connections. And I think bringing a feminist ethos of how can we be inclusive? How can we broaden the circle and bring in people who are typically marginalized or don't have a voice in global health? That's what motivated me, but also to think through how do we go beyond standard measures? The Alliance can have checklists, but I feel the commitment to gender equality goes much beyond putting certain checklists in grant applications.
Wonderful. So now let's fast forward to today. This is living in the present. Human resources for health is one of those building blocks that seems like a perennial challenge, but it's not discussed much these days. Why do you think that is?
It's one of the profound paradoxes of our time that the key actor that underpins our health systems is often overlooked, underpaid, undersupported, and is predominantly female at the lower levels of the health system, where you have the most interface with patients and users and communities. And it's how do we put a human face on those health workers? How do we look at affirming their humanity and empowering them as forces for change? There are many frameworks that look at why isn't the health workforce more productive? Many frameworks work on quality, work on standards, but fundamentally at its core is how do we affirm the dignity of health workers themselves, especially since a lot of their work is not just delivering vaccines and giving out tests and giving out tablets, but also how do they have a human connection with community members as a force for change, but also individuals who are coming in seeking help. Often with health conditions they don't understand themselves and can be just one part of a larger need in their lives.
Yeah, and some people might not see gender equality or social justice as a core or at least traditional HPSR. They aren't, for example, one of the health system's building blocks. So from your perspective, what does the approach of the Imarashi Consortium bring to the field, and how can it help us expand what we think of as central to health systems research?
So Imarisha means strengthen in Kiswahili. And we really felt we can't talk about strengthening PHC unless we look at health workers. And a gender lens to that means looking at the humanity and dignity of those health workers, not just in terms of which types of health workers, understanding them in their full totality. So it's not just looking by gender, but by age, by health worker profession, by how they're in the labor economy. So it's in hospitals, shift workers are particularly vulnerable. We have to sort of unpack the many different dimensions of who makes up our health workforce to support them more. So one role of Imarisha is to really put a flashlight looking at who these health workers are, but what are their daily lived experiences? And one of their daily lived experience is facing violence. And it's striking to me, every policymaker I've spoken to here in South Africa, every manager, and we just came out of a meeting with facility managers, they each have a story, personal story of violence, which has never been acknowledged, really. And it's striking to me that there's such a gap in our scholarship. It's tacitly understood. Every health worker that I've spoken to in South Africa or policymaker can recall vividly an experience of violence, even in their medical training or health training. You enter into the field with experiences of violence inflicted on you or inflicted on other people, and yet we don't acknowledge this experience as being fundamentally traumatic. It's demoralizing. It eats away at the fabric of our health system and our ability to respond. And yet it's not, there's a normalization of it, and there's a complete silence. And a gender lens, a feminist lens, is about giving voice to people, but also tackling those silences, looking at what are the topics that are not spoken about and trying to understand why, and how do we work with health workers and managers to address them.
You mentioned it already, there's a gap in the research when it comes to the lived realities of people working within the health systems, but both within the research, but also when it comes to influencing agendas and policies? What would you say is most key in being able to do this work?
So I think there are two elements of this. A lot of the interventions to date come from psychology and are about what kind of counseling and training opportunities we can have to help health workers cope better. And I think that's part of the role of health policy and systems research, is to change the frame. We started our conversation with paradigm shifts. There needs to be a paradigm shift, because it can't be just helping victims cope with the violence they face. We need to shift to a place where we build alliances to actually prevent, address the violence, stop the violence, look at organizationally and across what does the system have to do to support those individuals, and not leave individuals to handle this on their own. I've lost track of your question. There was a second thing I wanted to say. How do we affect change?
Yes.
How do we affect policy and change? So I think that comes back to, we need the numbers, but we also need the stories and the voices of people. When something has been normalized and accepted as part of the way injustice occurs and is allowed to continue, we need more than numbers. It's also the alliances that bring people together in brokering knowledge to impact change. And so you need to look at, how do we mobilize agents, connect people together? There are different groups working in their own silos. So HPSR has a role of creating connections to have policy impact.
Let's shift into the future now. This is leveling up. We're in a moment where gender equality, sexual and reproductive health, and rights-based approaches are facing renewed and sometimes coordinated pushback in many parts of the world. Given your long-standing work in these areas, what do you think HPSR as a field needs to prioritize in this sort of climate? What does the field need in terms of stronger evidence, stronger voices, or even different kinds of leadership as we look ahead?
I think HPSR has a key role to play in supporting different ways of thinking and framing issues. So supporting individuals, but those individuals work in broader organizations and larger societies. And I think that lens is key in understanding the pushback today, because the pushback has broader structural determinants to it. It's not representative of the values. If you look at the Maputo Protocol across Africa, gender equality has been signed as a key commitment. Globally, these are key tenets of universal rights. And health policy and systems research can help us understand what's behind this campaign. I think health systems have a key role if we are about defending universal health coverage, universal access to services. It means we need to stand up for the rights of gender equality, LGBTQI people, trans people, because these are the groups, even adolescent health. In certain countries, policies for adolescent health have not been passed because of this pushback. And yet they are, if you think of Africa, up to 50% of your population are young. How can you have a health system that doesn't represent their interests? Where are their voices? And I think health systems now more than ever, not just from an instrumental way of improving health outcomes, and these groups have worse health outcomes, but as a principle of fairness and a principle of justice, needs to remain open and not be undermined by this pushback on gender equality, and therefore needs to stand up for instance, how we provide sexual and reproductive health services to adolescents. How do we provide gender-affirming care to young people or even adults who are transitioning and don't feel comfortable with their gender identity? How do we make sure HIV and mental health services are provided in a holistic way to the people who need them because they've been discriminated against. And so the health service can play a key role in making sure they're addressing needs, and the health system, much broader than health services, is a key way of addressing the social determinants of health and making sure that people don't fall between the fault lines of inequality that has widened so much today.
Thinking about the next generation of researchers entering HPSR, especially those passionate about these topics, what kind of institutional structural support would help them to thrive if they wanted to research exactly the type of things that you were mentioning right now?
I think for me, research is a force for action, for change. So who are you doing that research with? It's a twinning process of bringing academic rigor as well as, I want to almost say social justice rigor, but that's not quite it. But it's being embedded in larger processes. Who are the activists? Who are the movements looking to affect change? And making sure that you are in conversation, because it's not just a paper you're producing. It's not data analysis in the abstract. If your work is to matter to make sure health systems are a force for change, it means being networked. It means being connected to those who are affecting change. And I think what's really also important is spending time developing those relationships in the health systems where you're located. That's important because things come up quite quickly. Think of COVID. It happened overnight. And having the networks and the relationships can help build resilience and help look at what are innovations that you can support as well, even as an academic. But you can't do that if you're just in a place for 6 months, then moving to another place. You really need to build relationships and understand context.
Asha, thank you so much. This has been such a rich and thoughtful conversation, and a reminder that we all need depth, courage, and care in our work when we are dealing with these types of issues. Before we close, is there any final thought or message that you'd like to share with the listeners?
If I look back on my career, some of the things that were incredibly meaningful were ideas and connections with people that didn't happen with funding. It happened because we identified a gap, and then we brought people into that conversation, and we created a collaboration, which then later got funding. So not everyone has the privilege to do that, but you have to seize the opportunities as they come and the connections you can forge and shape the funding opportunities that come rather than waiting for a funding window to open.
And so it's about making connections, collaborating, being creative to make that change. It's a few sets of C's I picked up in that
Absolutely.
answer, but thank you. And thank you to our listeners for tuning in to the Alliance Lift. If you've enjoyed this episode, please share it with your network, especially those working within health policy and systems research. You can also join the Alliance Alumni Network on LinkedIn to stay connected and hear more stories like this one. Until next time, take care and keep doing the work that lifts others too.